So you got all sorts of persons in this game with different backgrounds, experiences, doing all sorts of things. It's a bit Wild Westy. They might be shopping for you as a client, but like you have power. Shop for them and don't settle for something that is mediocre, because there is something out there that is just great.
Welcome to Psychedelic Source, where wisdom meets practice in the evolving landscape of psychedelic medicine. I'm your host, Dr. Sandra Dreisbach, and I'm here to help you navigate the complex intersection of ethics, business, and personal growth in the psychedelic space. Whether you're a practitioner, therapist, entrepreneur, or simply curious about this transformative field, you've found your source for authentic dialogue, practical resources, and community connection. In each episode, we'll dive deep into the stories, strategies, and ethical considerations that matter most to our growing ecosystem. Let's tap in to our inner source of wisdom and explore what it means to build a sustainable and ethical psychedelic future together.
The information shared on this podcast, our website, and other platforms may be triggering for some viewers and readers and is for informational, educational, and entertainment purposes only. It is not a substitute for professional medical, legal, or therapeutic advice. While we explore topics related to altered states of consciousness, we do not endorse or encourage illegal activities or substance use. Always research your local laws and consult qualified professionals for guidance. The content provided is, as is, and we are not liable for any actions taken based on the information shared. Stay supported and informed, act responsibly, and enjoy the podcast.
When working with psychedelics, it's very important to be aware of what medicines or medications, including vitamins, could possibly have an interaction with the psychedelics you're considering using. Now, the real question is, even if you're going abroad or into an area that's legal, what do you do? Who do you talk to? Who can you get support from? And there's one person who I'm really excited that you're going to hear conversations about with today, who's really made it his mission to really help and support people who are navigating some of these challenges from a pharmacist perspective. And if you have awareness of this space, you may already know him by the name Spirit Pharmacist, but his real name is Ben Malcolm, or Dr. Ben Malcolm. And he is my guest today on Psychedelic Source. He earned his bachelor's degree in pharmacology at the University of California of Santa Barbara prior to his master's in public health and working on his doctorate of pharmacy at Touro University of California. He then completed postgraduate residencies in acute Cara Scripps Mercy Hospital and psychiatric pharmacy at the University of California at San Diego Health. After residency, he passed his exam to become board certified at psychiatric pharmacy, BCPP. So he began his career as an assistant clinical professor at Western University of Health and Sciences College of Pharmacy before transitioning to current entrepreneurial role in psychopharmacology, consultant, psychedelic education, and founder of Spirit Pharmacist. And he envisions a society in which access to psychedelic drugs in a variety of safe and supported settings is available for purposes of psychospiritual well-being, personal development, and ceremonial sacraments, and treatment of mental illness. His focus on the intersection between psychiatric medications and psychedelic therapies. And I cannot tell you how many people make reference to his work, giving credit, not giving credit, and then this is just a call for people to give him credit when you're referring to Spirit Pharmacist, to Ben's actual chart of interactions and medications when you're pre-screening or when you're considering, because I feel like Ben probably doesn't get enough credit for his influence and support in making supported and well-informed choices for people who are approaching psychedelic medicines. Now, granted, we can't give medical advice here on this channel, so just another reminder here that please consult your medical professional or a psychiatrist or whomever you consult with before you consume any sort of medications. This is not here to advertise for therapeutic purposes, but it's worth mentioning that given that a lot of people in pharmacology don't don't focus on this sort of specific training area, and yet there's a high demand for psychedelic medicines. This is a really important conversation to have now more than ever, given how many people work with psychiatric medications and then try and pursue these journeys and experiences, even at a microdosing level. So please receive that proper medical advice. But I hope you'll enjoy this conversation with Ben Malcolm and I about himself, his journey, and also about how to do more safer, more supportive experiences in an informed way. Well, hi, Ben. It's so great to have you here on Psychedelic Source and being able to talk with you about you and your work and relationship. But maybe you could tell our community here a little bit about you and what you do.
Well, so wonderful to be here, Sandra. And yeah, so I'm a psychiatric pharmacist by training and background, which roughly means I completed pharmacy school. So I have a doctorate of pharmacy. And after pharmacy school, I spent a couple of years in residency programs. So I did a first-year residency program just in acute care or in hospital-based pharmacy. And then I did a second year that specialized in psychiatric pharmacy. And from there, I passed a board certification exam in psychiatric pharmacy. So that's essentially when I say, like, I'm a clinical psychiatric pharmacist. Like, how does that, like, what the heck is that? And how does it really even differ from probably where like 70 or 80% of pharmacists are found, which is in the retail world, places like Walgreens and things like that. So basically, I did a couple of years of postgraduate residency in different types of clinical or hospital-based healthcare settings that got me to really specialized in psychiatric types of medications and mental health conditions generally. But I have to be frank in that I had a very long-standing interest in psychoactive substances even before I chose that specialized path towards the end or even after
really?
Pharmacy school. I mean, I'd just been fascinated with psychoactives or even like addictive types of substances as a teenager. There was just an experiential and intellectual kind of curiosity there. But I think that was different, right? It's like a lot of teenagers, I think, have some sort of experiential curiosity, but mine was extremely intellectual at the same time. Like I just didn't, like I wanted to know, why is it that drugs that had physiologically opposite effects like cocaine and heroin would converge in this like behavioral pattern of addiction? Like I didn't really like understand that, and I wanted to. And so it led me to, every mother's wish come true. They come in and it's the evening time and, their teenage son is looking up illicit substances on the internet and just reading different anecdotes about them and things like that. And so it was through that process that I came across psychedelics like psilocybin mushrooms or MDMA, and just reading anecdotes of things like methamphetamine, cocaine, heroin versus anecdotes around psilocybin mushrooms or MDMA. It became apparent to me that even though they're all regulated as illicit substances, the pharmacologic effects are very different, and the average trajectory of use is very different as well. And, I think that this speaks volumes that by the age of 16 or 17, just through reading on the internet, it's just apparent that the public health policies or the drug regulation policies of the country that you're living in are not evidence-based, they're not altruistic, and they're not really set up to protect public health. And there are certainly examples of drugs in this category which don't even really fit the definition for being in the category, which to be an illicit substance, it has a high potential for abuse and no therapeutic potential
use.
or
Yeah.
ability to be used safely under medical supervision, right? And
Yeah, and I think that's a really important point.
Those things were not true about psychedelics, I don't know, when I was discovering this like 20 years ago, and they're definitively proven not true about psychedelics today. So it's been a long, circuitous, educational, and interest-based path. And I would say that, I had no, like when I was like getting into this stuff or like just kind of like feeding this interest as a teenager and going into undergraduate, I had no conception that this is what I would do in the future. But at this point in time, I've taken all of my skill sets as a clinical psychiatric pharmacist, and I function as a psychopharmacology consultant through a website, spiritpharmacist.com. And I essentially try to be an informational bridge between a psychiatrist and an alternative health practitioner that facilitates psychedelic substances, or maybe less alternative, but maybe it's like a therapist, or there's lots of different professionals, I guess, in different settings that could potentially facilitate a psychedelic experience. And I'm really trying to bridge an informational gap so that the person that's interested in this modality just has enough information about their mental health conditions, the existing medications they take, and the types of things that they're interested in doing or trying so that they can make sound and empowered healthcare decisions for whatever they really want to do. And sometimes it's, I do want to do it after that conversation. And sometimes it's, wow, there's a lot more risks here than I really sort of thought or anticipated. And it doesn't seem like the kind of thing that I want to do right now, perhaps. Yeah.
Yeah, and I love this, and I love your story, and I'm curious, like, what was the first drug or substance as a teenager that made you go, "Huh?" Like, where was the real inception piece for that intellectual curiosity? Like, was there something you saw? Was there a person? There had to have been something. It couldn't have
Well,
just
I
come out of.
kind of said it backwards in the story. Like I said experiential when I meant intellectual, right? And so it was actually A&E. It was like that reality TV show Intervention on A&E, where it was
Ah,
basically like they had like a person and they'd be horribly addicted to some substance, and then it would be like let's get all their closest friends and family, invite them to a surprise meeting, and then basically be like, you go to rehab now or you're cut off, right? Which is frankly just a horrible, horrible model for treating addiction and substance use disorder overall. But, this is the late 90s, early 2000s, like the absolute peak of total trash reality TV, right? On the heels of Jerry Springer and things like that. And so it was like, wow, it was like fascinating kind of stuff that stoked that intellectual type of curiosity, but it was psilocybin mushrooms I ate when I was camping my senior year of high school when I was 18 that really sort of like,
oh,
wow,
yeah.
wow, 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 like nature is alive and I'm a part of that. I didn't really realize that before. My parents would drive me around to just gorgeous places like the Grand Canyon and stuff and be like, all right, let's get out and take a look, and be like, Donkey Kong on Game Boy is more fascinating than this. Like, can we
That's
move on
hysterical.
yet? Ooh, I'm bored.
Yeah, yeah.
And it's like, this is literally one of the most mystical, magical, natural things you could possibly lay your eyes on, and you can't even see it. You know what I mean? Like,
Yeah.
you just can't even
So for
see
you,
it.
there really was, like, this combination of, like, that intellectual stimulation and curiosity, but also noticing from your own experience a real shift of experience after having had an experience with the mushroom. Yeah.
Yeah. Yeah. Like, I mean, that they always did something for me, right? And it's not like as an 18-year-old, I was kind of like, ooh, psychedelic-assisted therapy. And, like that really wasn't, I mean, I'm sure it was a thing somewhere, but it wasn't a thing on the sources that I was reading about
Right. It
psychedelics
wasn't
from.
it
And it
wasn't as
wasn't
common
something, I mean,
knowledge.
yeah, well, I mean, this is like 2002. Right? So it's
Yeah.
like, I mean, Roland Griffiths published his seminal article on the mystical consciousness of psilocybin that essentially kind of repeated some of the themes of the Good Friday experiment in
Right.
2007, right? Like these are like real early days where the National Institute of Mental Health might be just starting some trials of intravenous ketamine for refractory depression. So it really isn't 2010 through 2016 yet where all of a sudden there's randomized trials for MDMA, psilocybin, S-ketamine or Spravato is getting approved. The FDA is giving breakthrough designations to MDMA or psilocybin.
Right.
That was the era where I was just finishing my PGY2 year in psychiatric pharmacy. So, and sometimes when people are like, how'd you get to be doing this? I'm kind of like, well, I had a long-standing interest, but I also was just in the right place at the right time, and that the culmination of all my graduate school and training just so happened to coincide with when the time that the world got really interested in this overall.
But you obviously had a personal interest because, like, I mean, it's not like the standard fare that the clinical psychiatrists are like, "Yeah, let's integrate, psychedelics in
Yeah,
our work." It's like I'm
yeah.
not going to. I mean, as much as I love my Walgreens and my Walgreens pharmacist, thank you for your work. I don't ask them about psychedelics.
Yeah, of course, right? But I guess what I'm saying is sort of like even in pharmacy school, like 2010 to 2014, it's like we get to the where we talk about psychedelics, and the lecture's called like hallucinogens of abuse or something like that. And we're getting into this lecture and this and that, and it's like, it's like, well, blah 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 blah. I can tell you about peyotism and its origins as a religion, or right, like I can't
It's
pronounce
more
it,
of
but
a
I can tell you
novelty.
that like it's like, oh yeah, Teo Noctil, like flesh of the gods, like that's what that means as far as the mushrooms, right, and things like that. And the teachers and professors would be like, I mean, like the students, I mean the other kids, that like it was like tongue in cheek, but like a little bit real. They'd be like, Ben, you're like the captain of useless information. It's like like so much about things that are completely irrelevant to the world of pharmacy. You know so much about the world of drugs that's just irrelevant to pharmacy. Was like how it was like 2008 through like 2014 or so. And then all of a sudden, the world got interested in the useless facts,
Right.
and
Right.
it became like, this is incredibly valuable information that we can't get anywhere else. And so right, the world got interested in the things that I was just like nerding out on for a decade before that.
No, well, but the fact that it was even seen as, like, not even useful in terms of your main training, right? That not only was it not a focus or not even like, "Okay, here's a special class on
Yeah.
psychoactive plants and, the medicinal uses," right? Or how to help that pharmacologically if you have a patient who has those issues. It wasn't even on the official radar. It was not considered, at least some of the conversations, right, useful.
Right. Well, I mean, like, how can it be useful? Like from the angle of your profession, like, how can it be useful if the substances are regulated as illicit substances, and
Right.
you're training pharmacists in pharmacy school?
In
Are you
legal
going to be training
pharmacy.
them to sort of be like, you know what, the lines of the law, you decide where those go, and this class of substance that the FDA has not approved for a medicine and is supposed to be, too dangerous to be used even under medical supervision, right? Like from the angle of a profession, like from the angle of the profession's ethics, the
Right.
professionals should never cross legal lines, right? And so anything that exists over a legal line informationally is just going to be viewed from the angle of that profession as useless information, right? But from the angle of the public, it is not useless information, right? And I always just thought this just like generally is kind of like before I thought of spirit pharmacist, right? Like I literally thought of street pharmacist, right? Because I was just sort of thinking along the lines of, well, here we are in inpatient psychiatry, and this person came in and their urine toxicology lit up like a Christmas tree with cocaine and amphetamines and things like that. And they're coming down and crashing, and of course they're horribly depressed and blue as far as coming down and crashing. And now the team is like, let's start Prozac, a CYP2D6 inhibitor. So
Oh
so
my
let's
god.
get this straight. We're going to start an antidepressant that is actually going to interact with cocaine and bump its blood concentrations. It's like, is that going to be a smart plan for that person? Are we convinced that this 72-hour hold is going to be enough to stop their cocaine habit? Or are they
Definitely
going to
not.
go out and,
Yeah.
unless we get them teed up with some kind of treatment, probably use again? And we actually just increase the hazards of them using cocaine by giving them a strong CYP2D6 inhibitor in the background now, right? So there's sort of like a relevance to considering that not all of your patients are going to stay within the sandbox of the lines and may not
Right.
even be able to do those kinds of things. And unless you're going to provide a real intervention and plan for them, right, we probably shouldn't be prescribing any medications that just interact with the illicit things that they're doing on the outpatient side, because we want to reduce harm, not increase it by,
Yeah.
adding something that's going to be a metabolic monkey wrench to the illicit substances that they are most likely going to continue
No,
using and
and
things
that's
like
it's
that,
even
right? So,
beyond, pragmatics, like it
yeah.
really is, I mean, and maybe this is too soon to bring this up, but like people talk a lot about now about fentanyl, and they talk a lot about opiate abuse and addiction, and part of the blame has been pointed to the pharmacological industry. And the overprescription of oxycodone, right? And other, opiates, right? That are legal opiates, right?
Yeah.
That are trained, that are part of the official, bread and butter that we can talk about as a trained pharmacist. Like, I am not a trained pharmacist, just to be clear. And um, and yet, there's this rift between talking about these other quote unquote illicit substances that actually, as you mentioned, right, have therapeutic use with medical supervision, which is, I think, the argument you're suggesting, which I would agree with you, but I cannot say from any of my professional. I'm an ethicist, right? But how do you show up as a pharmacist with the knowledge that you have to really help people in a grounded way within the means of your profession and maybe outside. I don't know. I don't know what the strictures are, given the environment, right? Because we can't, just like you say, like we can't ignore what people are really experiencing, what addictions or dependencies they may actually have, regardless of where they come from. If you really are going to serve people based on clinical pharmacology.
There's a lot of things there, right?
I know, yeah, sorry, that was
So
a lot.
so so first of all, I really do believe that the pharmaceutical industry played a huge role in the current day opioid epidemic. It was probably the mid 80s, and at that point it really was like opioids are for acute surgical pain or pain associated with terminal illnesses like cancer, right? But it really was not for any kind of like, oh, I have osteoarthritis in my hips, or it really wasn't for any kind of like chronic, ongoing pain kind of indication. Was not really a use case for opioids. And then, it was petitioned and petitioned and petitioned. It's like, well, this is cruel. We have a tool that
Yeah.
we could relieve suffering with, and they're suffering chronically, and we're going to withhold that? How cruel, right? But of course, there was no long-term trials of opioids demonstrating that they actually reduce pain in the long run and reduce a person's suffering in the long run. It's all limited to like acute surgical things and stuff like that. And so you got this kind of creep of pain meds out of, right, like almost like terminal situations or acute surgical pain, basically into any chronic illness that has pain, which, I don't know, for a population that's got some extra weights on their joints and eats a hyper-inflammatory type of diet and things like that, is like you got a lot of people with chronic pain that all of a sudden qualify for opioid use. So that was sort of on the outpatient side. And then the inpatient side of it, I mean, JACO, like the Joint Commission of Hospital Associations, in around the year 2000, added pain as the fifth vital sign. Respiratory rate, heart rate, blood pressure, temperature, all of those are objective measurable things. And then how much pain are you in 1 through 10? And, and flipping the remote and having a pork sandwich and 11.
Yeah, or the
Oh,
smiley
here,
face. Have you seen the smiley face
better
indicators?
bump it up and have another shot of hydromorphone or what, right? So it sort of became this like, hey, why are we measuring a subjective pain score like it's a vital sign, like it's an objective kind of like measure, right? And it was like, well, pain must be treated if there is pain, right? So all of a sudden you got a lot more pain med use inside of inpatient settings or hospitals as well. And then, of course, you've got, Purdue Pharma and Oxycodone and their pharmaceuticals rep strategies, which, I mean,
Right.
I think it's the city of
Unethical
Los Angeles
strategies,
has
right,
sued
yeah.
them for racketeering. And, it's an alleged thing, but I would be willing to testify for the city of Los Angeles. Let's just put it that way, as far as like the strategies that they're using to sort of advertise these types of things. I mean, why the heck you're advertising Schedule II controlled substances that are habit forming? I mean, you shouldn't need to advertise those types of things. Slash,
Yeah.
every other country in the world would just make that illegal at baseline. So yeah, that's like, I do think the industry had a big piece in that.
But I also wanted to bring up, I really appreciate, I want to take a pause on the notion of chronic pain, because I think that's a really important subject. And uh and I know, at least for myself, like I have friends who have, severe chronic pain, and What first opened me up to microdosing years ago was having a friend who had experienced chronic pain, who had done all the official like chronic pain management she was told by her doctors, right? And either she'd be too doped up, right? And so start opening up to doing some intranasal ketamine and some doing, low dose of MDMA and some other things to try and literally self-drug herself into the right amount of a pain management strategy, including pharmaceuticals that were given to her by her physician, and finding herself in this sort of self-subscriber, prescriber situation. And it really made me think differently because simply because, like, and she also would use kratom, right? And finding these different strategies to try and mix because, like, having opiates all the time wasn't really a functional option. Um, you know, f Lots of different reasons, right? And I've met a lot of people in the chronic pain community who've turned to psychedelics and psychopharmacological solutions, or I did a lot of kratom advocacy just by that, just because it was an opiate alternative, right? It's not a solution in of itself, anyone out
Yeah.
there. But, so I'm kind of curious, what I know a lot of times people associate, spirit pharmacists with, how to find the right match or that your lovely chart
Yeah.
that has served a lot of people, and you probably don't get enough credit for that chart. Um, because I know it's helped a lot of people. I still remember meeting a UCSC student of mine before I was talking about psychedelics, showing me a chart. It wasn't yours, I think it was someone else's, but I was just, like, shocked at, like, he was looking at it as if it was, like, the perfect recipe chart. I'm like, "Okay, I can do this, and then I can do this." And I'm like, "Hey, that was really disturbing to me." But at the same time, I'm like, "Well, at least there's someone who's trying to tell people how to manage these things and give them some real world advice in a pragmatic sense." Like, people don't want to risk their health by working with psychedelics. And sometimes people are trying to help their health by working with psychedelics. Could you
Right.
speak a little bit about, who are the types of people that you end up helping the most?
Well, I think it's less in like a person that has like chronic pain that's like kind of like on opioids. Like I do meet some persons like that, but
Yeah.
frankly, it's a lot of persons that usually they're over 35.
Mhm.
Usually, not always, right? I get quite a few that are in the 20 to 30 range, but I'll say like 60% ish. 60% of the people that I speak with are age 35 to 75, probably about two-thirds female, like compared to male. A lot of them take antidepressants. They've been taking antidepressants usually for a relatively long period of time. So I think that's like one, like just mainstay person is a middle-aged female that's been taking antidepressants for a period of time that they typically work for some period of time or they helped a little bit, but they kind of tend to peter out. Maybe they've tried to stop them a couple of times and it's been not very successful or like kind of like partially successful. And then they're looking at either micro dosing or using larger doses of psychedelic with guided support kind of as an alternative. And then I meet a lot of persons that have they're somewhere with a bipolar spectrum, right? And so it becomes like I think severe bipolar disorders are really thought of as almost a black and white contraindication for psychedelic use. But there are sure are a lot of people out there that are diagnosed with either a very mild type of bipolar condition or it's really questionable. Like it's kind of like maybe you have a bipolar condition. And it's a lot of those types of people that we end up doing fairly individualized types of evaluations on and sort of trying to figure out like, hey, which side of the fence might you be on? The side that is it really is kind of higher risk to the point that it may not be in your favor to try that? Or hey, we could think about a couple of these things as red flags, but there's also some mitigation strategies and ways that we could reduce harm. It's kind of like you have a few choices, right? You can say driving is dangerous, so nobody gets a license. Or you can say driving is dangerous, so you need to pass the test to make sure that you have a license. And then if you go driving, you got to stay on this side of the road. And we want some safety features in that vehicle, like seat belts and airbags. And then there are some stop signs and red lights and things that you're going to have to pay attention to as well. What are the choices here? Tell the person with a bipolar condition, nah, psychedelics aren't for you. We're not going to touch you with a 10-foot pole because you're bipolar and crazy. And then what? They're applying to the next retreat center and not disclosing their bipolar condition, or just ordering the psychedelics and eating them themselves at home. Two situations that we probably really want to avoid because they're higher risk than just actually evaluating the person and trying to button it up with a harm reduction kind of approach.
And what are some of the strategies that you tell people? Because I think you're absolutely right. Because like people know about the whole, like, oh, people only with unipolar depression were approved for a lot of the research studies, simply for the simplicity of a research study, by the way, people. Doesn't mean that it's, counterindicated necessarily for bipolar. It just means it's simpler, or what they chose. And I can't speak for that as a researcher in that sense. But I think a lot of people are eliminated just because, like, oh, if you have any history of psychosis, if you have any history of psychiatric disorders, if you have been diagnosed with bipolar depression, let alone the fact that people are misdiagnosed with that, um, that they'll either will not disclose it to people and still be part of those experiences and increase their risks by not disclosing to people, or simply they they'll actually take on additional risks by combining it with their medication, right? What are some of the general pieces of advice that you give people who have some of these, quote unquote, counterindications? I know each case is different, and I know you can't, you know.
Well, so yeah, exactly. So each case is different, but what kind of things that could we look at to sort of like tell those differences, I guess, right? So one of them I think is just the age of the individual, like overall. Like bipolar conditions are usually diagnosed at late teens through mid 30s or so. So when I get a person that has a bipolar condition and they're 19, right? Or maybe they're 19 and they only have a unipolar condition so far, right? It's like that's an age range where there is a potential to unmask a more serious condition, and probably a good 2/3 of the time, maybe 3/4 of the time, the person is going to present with depression before they present with mania. And you spend usually 2 to 3 times more time in depression than in mania. So if you have a bipolar condition, usually you're more bothered by depression than mania. But if you're society, you're a lot more bothered by mania than depression. So there's a little bit of like, we're not necessarily seeing the condition on an eye level as far as like what our goals are. I think society's goal is no mania ever. I think like the person's goal is usually, I wish I could get out of bed and function. And I would much rather be going a little too fast than this slow, like overall. I meet a lot of people in inpatient psychiatry that are like floridly manic, and then you treat them with mood stabilizers or antipsychotics for a few days, and 3, 4, 5 days later, and they're like, Doc, and the insight comes back. They're like, Doc, I know I'm going too fast, but don't slow me down too much. Because they fear the depressive pull, like seriously. They're kind of like, oh no, after this mania ends, it's just
I'm gonna
sort of like
crash.
flattened out. So I think psychedelics are probably helpful for depression, whether it's unipolar depression or bipolar depression. I think particularly the serotonergic psychedelics may have a real risk of precipitating mania, and we've seen that before. I think dosing and sets and settings do make a difference as far as the risk of that goes. Some other things I like to pay attention to, right, are the substances that you've tried in the past and what happened with them, right? Because SSRI monotherapy, just antidepressants, can push a person with a bipolar condition towards mania. Heavy cannabis use, particularly high THC varieties, things like nitrous or PCP, prednisone, and corticosteroid types of medications. Psychedelics. Some of them have tried them before. And if they've tried psychedelics 15 times in the past and it's never, ever been associated with mania, that starts to feel sort of reassuring in some ways compared to a person that is 22 years old and psychedelic naive and had a manic episode in response to taking Prozac the first time they were prescribed it, right? And so by looking at kind of like the age, and I'll say like how many episodes of mania have you had? Have you ever needed to go to the hospital for it? What kind of treatments worked for you? Right? If they're kind of like, oh yeah, like 100 milligrams of Seroquel and a half milligram of lorazepam twice a day, it's like it puts the brakes on and it stops. And it's like, all right, well, maybe we need to make sure that we have a bottle of Seroquel and lorazepam on hand then if we're going to do this, right? That feels like the seatbelt and airbag type of thing, right? Rather
Exactly.
than, well, I haven't seen my doctor in a year and I sure hope I don't get manic and I'll have to call up their office in 3 weeks from now they can see me. And it's like,
No,
oh,
no, no, no,
well,
no. Yeah.
that was a bummer, huh? We probably should have nipped that in the bud ahead of time, had emergency prescriptions on hand or either called into the pharmacy to pick up, then maybe even put an appointment with them on your calendar 3 or 4 days after whatever you're planning so that you can check in with them and they can evaluate their mental
And that's
status,
so
or
smart.
a therapist that knows you well, or a partner that's seen you across years in a few different states, right? It doesn't necessarily have to be like a concierge doctor that you hire for hundreds of dollars and things like that. It can really just be somebody that knows you well that would be able to look at you and say, like, you're talking really fast and I can't get a word in this conversation right now. And that's concerning to me. And so this is whatever the next step is. I want you to take that 100 milligrams of Seroquel tonight, and I'm going to call you again in the morning, right? And really start following close at that point. So that's what I mean. Like, there's a lot that we can do as far as checking under different kind of stones, as far as treatment responses, things you've tried, things that set off mania, things that really didn't, treatments that have worked, treatments that have been adverse, and there's no way in heck we're going to retrial them, right? Like, what does the support look like as far as persons that have helped you in the past? Can we put that in place? Probably not traveling to South America where you're out of touch with the world and off grid and gonna do, you know, 8 ceremonies in 9 days or something like that, right? Like sometimes laying on the sauce really thick in places where you can't get immediate help should you need it may not, I mean, that's a higher risk scenario overall, right?
No, and I really love all of what you're sharing because first of all, what I really appreciate hearing is this aspect of partnership that you're showing, like, not just in terms of, as a pharmacologist, working with the patient, really listening to them, listening to their personal history, understanding that, which obviously I feel like all pharmacologists should do, but also this aspect of like, well, what has been your history? Plan can you put in place if you are going to have these experiences? Given your risks, what kind of and having that sort of team approach, whether it's like a friend, a family member, working with, whoever they currently work with as a pharmacist, right? Or their therapist, clinical or otherwise. So that it's not necessarily like it's not a hell no, right? It's like, well, let's really look at this. What real risks, let's really think about it from a real practical standpoint and prepare you, like you said, put on, have a seatbelt, have the supply. You can still go driving, but you may need like a spare set of glasses, or you may need someone else who can drive if you really can't drive, or maybe you can only do one ceremony, or maybe it should be something more local, you know, um, a different way of looking at it than just saying like you can't. And who's our special guest here today?
Oh, we've got, well, this is
Hi,
her full name is Samadhi, but it's
hi,
just
Samadi.
Sammy, and have some people that are helping us out downstairs, and Sammy's very territorial. She's not a huge fan of intruders, huh? And even if it's an intruder that comes every single day and is like super friendly, it's like the same thorny welcome from this one. Yeah.
Who's a good protector? Well, and maybe we should take a tip from Samadhi here. Like it's about having practical protection and support, right? I mean, like I think there's a lot of people who I'll hear like, "Oh, you have to get off of all of your substances, I don't care what it is, wean off of everything." There's also like a sort of anti-pharmacological sort of orientation sometimes in the psychedelic space that's like, "No, you shouldn't be having any chemicals, any
Right.
synthetics in your system, and we need to get you off of all of it." Um, Even if they're quote unquote tapering in whatever their sort of version of tapering is, there seems to be, at least, and this is just my personal perspective, a lot of, people winging a pharmacological mindset, but from an uninformed lens. They're like, "Oh no, I've seen this multiple times. I'm
Yeah.
really experienced at I've been working with people with this medicine for 10 years. I know exactly what I'm doing." Right? Um, what kind of advice would you give someone who's thinking about I know obviously again, can't give an advice for everyone because you have to work with them individually.
Yeah.
But but what do you say to the mindset of like don't use with any pharmacology?
Oh, it's very puritanical, it feels like,
Yeah.
right? Like it kind
All or
of,
nothing.
yeah. I mean, on the one hand, it's almost like prescriptions are a bit rampant in some ways, and I do think that there's a level of over prescribing with certain
Absolutely.
meds and classes of drugs where the sentiment of like questioning and becoming curious about like, do we really need all of those, and is this really the best regimen that absolutely serves you overall? I think getting into psychedelics and doing psychedelic therapy, it's just a wonderful opportunity to reevaluate those things, because we're probably going to need to evaluate the drug regimen as part of the screening
Yeah.
process anyway. And so it makes a heck of a lot of sense to me to motivationally interview about how you got to be taking this prescription regimen, what parts of it works, what parts of it really doesn't work, which parts I have no clue whether it works or not, right? Because I think that those are sore spots to me as a pharmacologist. Like, I'm kind of like, persons should be taking medications and they should know why they're taking them, what they're taking them for, and there should be a clear upside for them. Even if there's some kind of side effect, there should be an upside that outweighs whatever kind of side effect burden or other thing that kind of like comes along with it. And if we're not clearly in a position where that's true, it does seem like something that should be questioned or reevaluated. And at the same time, if you question and evaluate it and it becomes, thank God I started this one, because you know what? It really pulled me back from the edge and it's continued to work like a charm and I don't really have any kind of problems with it. And you know what? I was interested in this psilocybin experience because I was reading about the spiritual effects of it. And only when I applied to the center did they say, hell or high water, you have to stop all of these for 6 months. And I thought, really? Is that correct? And it turns out it's not correct, and it turns out that probably doesn't serve me very well, right? So it's about doing what wise and doing what works, and there's a lot of bathwater in psychotropics and pharmaceuticals, but occasionally there's a baby in there too, right? And so it just becomes this process of, right, like, okay, you want to sort of change treatment directions and do something a bit alternative. And those alternative things frankly may not be that compatible with your baseline prescription regimen. And a lot of people that I'm talking with, they want to try this other thing because their existing thing really isn't working that great for
Right.
them. And so it's going to make a lot of sense in a lot of these persons to really take a hard look at the meds and evaluate them. But it's not going to make a lot of sense just to blanketly tell people to stop things that are helpful for them, like overall. And there is just so much. Right. It's kind of like picking and choosing as far as like the stigma goes. Right. Like for example, here's a good one for you.
Okay,
Right.
let's
It's
hear.
kind of like
Shoot.
I have, Betty Boo, who's 32 years old and started to take a low dose of an amphetamine for ADHD a year ago. And since taking 20 milligrams of Adderall extended release a year ago, the person has been able to complete more tasks And that's made them feel a heck of a lot more confident about themselves, and their depression's actually sort of lifted almost as a result. Their anxiety seems better because they're not like on the brink of procrastinating and not being able to do the thing. It's kind of like I do it and like I feel good that I did something, and it sort of like builds my motivation so I don't feel so like low and depressed. And then I'm not like overwhelmed and stressed because of all of these like loose end things that I haven't like done. And so man, like I'm a pretty happy camper with it overall. And then they talk with Guide X, and Guide X says, well, Adderall is clearly very dangerous with psilocybin mushrooms. You need to stop that 2 weeks ahead of time. But let me ask the spirit pharmacist if adding 100 milligrams of methylene deoxymethamphetamine is going to be a good thing, right? And so
Oh
that's
my
just
goodness.
it, right? Is like, why is 20 milligrams of Adderall XR a clear contraindication with psilocybin mushrooms, but 100 milligrams of methylene deoxymethamphetamine is boosting the healing and no safety issue? Right. And so it's kind of like, well, if we're worried about the safety issues of 20 milligrams of Adderall, we should probably really be worried about the safety issues of 100 milligrams of MDMA. And I get the therapeutic intentions of using them in the context are very different. And it very well may be true that adding MDMA to psilocybin offers some depth and experience or neuroplasticity, or like there might be some like additional healing effect. I'm not trying to say 20 milligrams of Adderall XR is the same as pharmacologically as 100 milligrams of amphetamine, but guys, they're both true psychostimulants. And so if your concern was risk of stimulants with mushrooms, your concern has to be equal, if not more, because the dose of MDMA is just high compared to that 20 milligrams of Adderall XR at that point. And so that's what I mean about like the stigma of psychotropics is you could have a psychedelic that truly has stimulant effects, and it's seen as just like a friendly ally where nothing can go wrong, yet 20 milligrams of Adderall, amphetamine salts from the industry, stop
Right,
putting that
that
poison in
one's
you if you
bad,
actually
this
want to
one's
heal.
good. So because this
Right,
one's a friendly, we decide that this one's okay versus the fact that like in terms of the action or the chemistry, right?
right.
Or in terms of the effect for the person
It's
or
like
the risk
Mr. Mackey's
profile.
wearing a tie-dye shirt, right? And he's
Right.
like, Mr. Mackey is totally stoked on LSD, but then he's like, drugs are bad, okay? Still.
Yeah. Yeah.
And I
Yeah.
think that almost circles back to like part of the previous discussion. It's like, well, I believe psychedelics should be real medicines because the safety and efficacy of them is there. Like you can truly demonstrate they should qualify as medicines. But if it came down to sort of like harm reduction, I would vote to just get rid of the C1 category, period. Right? Even crack cocaine. Okay, maybe it doesn't have the therapeutic upside to it. We're not going to do a randomized trial that show it works for asthma or something pretty soon, right? Or maybe it does work for asthma, but it blows up your heart at the same time. So that risk benefit trade off isn't so good. Right?
Yeah.
Right. But would I want crack cocaine to be an illicit Schedule 1 thing? No, not really, because it just perpetuates a drug war. It just perpetuates harms, right? So from like I want harm reduction across the board, which to me would mean I don't think having a Schedule 1 category reduces harm, and I don't think it's aligned with public health or just evidence-based policy around drugs generally. So it's like I would vote to just get rid of it, get rid of that for all substances, but like which ones like could be made a medicine relatively quickly? I think the psychedelics, because the data is there. But even
Yeah.
then, like let's just say we got rid of the illicit drug category, made everything a Schedule 2 controlled substance. Doesn't change very much, to be honest, because if I get caught with a bottle of oxycodone, a Schedule 2 controlled substance, that's a criminal act still if I don't have a prescription for it. So you can still bust me. Right? You can still bust me, right? It's not like I took law enforcement's ability to, bust people that have illegal prescriptions away. So what did I do really? I just made it so scientists can study the drugs easier. So the Schedule 1 category is inherently not about public health policy and keeping people safe at all. It's about having a bucket that you can put stuff in so that you can't find out the information. And that's unethical. That shouldn't be anything that anyone wants, right?
And all the examples you've been giving are really, showing this. Like, by having these substances criminalized to such a large degree, it's not only a barrier to those who actually want to have a healthy mental health and are trying to work consciously with the substances they're currently working with, but a barrier in terms of even people's understanding with people who are trying to be, and I would say a lot of people, people in general want to be responsible with their use, in my humble opinion. But I think there's a misunderstanding, like about, like you're saying, like, well, I want to combine their psilocybin experience with the MDMA, but they don't see it as the same as the amphetamine they were taking for their ADHD, and people see it as qualitatively different, and that's because of the way that the alleged drug war has approached these substances, and how we've been educated and miseducated about risk and harm reduction on either side of the quote unquote fence. What would you say? What advice would you give someone who's coming? Like what kind of sources of information and support would you advise people who want to work with psychedelics in the environment that we find ourselves in right now to help educate and inform
Do
themselves?
do your research.
Do your
And
research. But does
that
Google
doesn't mean
count?
sitting on YouTube and watching anecdotes of people's trips all day, right? What I mean by that is that, hey, I think psychedelics work, to be honest, and I think that they're relatively safe in controlled sorts of environments. But frankly, this is the Wild West right now. Frankly, this is just the Wild West. And if you have a mental health condition, like if I'm doing research at a university or someplace and I'm trying to get a study approved, right? Like ethically, there are special populations, right? There are like minors, pregnant women, prisoners, persons with mental health conditions tend to be in buckets of special populations where we think there might be additional risks because of some level of desperation, or right, there's just other things kind of involved. Okay, there's a fetus in pregnancy as well. Like the stakes are very, very high if the
Absolutely.
trial's not going well and things like that, to the point that it becomes very difficult to study in some ways. So I think you need to sort of, first of all, I think a lot of people getting into this are under the impression that their options are really limited. Like you're coming from the mainstream. You don't buy illicit drugs. Right? You're probably likely to kind of like come across someone and like, oh, I found someone. Okay,
Right?
well, there's a
And the first
thousand of
person you
them
come
at this
across may
point,
not be,
and
yeah,
it's like therapy. They fall on a bell curve. Some are great, some are not so great. Some of them are great therapists, but they're not a great fit for you, right? Because it's another human being and their energy that you're essentially interviewing, as well as the space, right? So I think my advice is like, take a breath, slow down, realize there's a bunch of options, probably some that you're not even aware of. Like, frankly, if you're coming from the mainstream, there's hundreds of psychedelic compounds. There's lots of people serving them in all sorts of which ways and things like that. You come across the first person and they're an incredible fit, great. But if you come across the first person and they're an all right fit, keep looking. Ask hard questions, or not even hard questions, I don't think, but just ask questions, right? Like, how long have you been serving psychedelics to persons for? What was your background in either mental health or healing or the world of psychedelic substances before you were doing this? What kind of training or mentorship experiences did you have before you started serving persons psychedelics? How many people have you helped? And do you usually help people that have mental health conditions that are taking psychiatric meds
brilliant.
or not?
Yeah.
Right? Who do you think you're most qualified to help? Like overall, like who would you say is like the ideal person for you to serve psychedelics to? And I know some persons that they work pro bono with trauma survivors, and it's like beyond trauma. It's like almost torture what they've been through and like things like that. And I know some other persons that are literally looking for like whale diplomats, and that's the only person that they want to serve because they think that if they can change one of their minds, then they can change the meeting in an international affairs room, which will change the world. just like that, right? So you've got all sorts of persons in this game with different backgrounds, experiences, doing all sorts of things. It's a bit Wild Westy. And so you're going to need to really kind of, right, like they might be shopping for you as a client, but like you have power. Shop for them and don't settle for something that is mediocre, right? Because there is something out there that is just great. And yeah, I think that's just it. Is there's usually a lot more options than the person realizes. It takes a little, like it's not as easy as dialing up a pizza from Little Caesars. Like it's
That's
not.
right.
And in some ways, I don't know. It's almost like, like, should it be that easy?
Yeah, you don't
Or
want
is
it
it
to be that
actually
easy,
like,
people.
I
Yeah.
don't know. It's like I hate prohibition, but it's almost like the blessing of prohibition in this like Wild Westy psychedelic environment. It's like if we would have just like rubber stamped psychedelics in the year 2000 or something like that, it would probably just be so loose and fast like the rest of the pharmaceutical industry that you would just be kind of like running into all these misadventure types of things. But because it really is this sort of like, so we're going to get it. All right, I got to have conversations with like 3 or 4 people before I even like find a source. And then I learned something about this modality along the way. And then I finally found a source and they told me I had to go watch this documentary over here and I had to go talk with the spirit pharmacist over there. And then all of a sudden, I know so much more about psilocybin mushrooms than I ever knew about SSRIs. And they're actually empowered to choose something instead of just kind of like, oh my God, I shed a tear in my doctor's office, and before I knew it, the Lexapro prescription was being slid across the desk, and I was like, what's this? And they're
Yeah.
like, just take it, it's going to help you. And so I started it, and then 10 years later, I'm like,
Why am I
did I
taking
start
this?
this?
No,
Yeah.
I've had that experience with certain things, and I just really appreciate that advice of just asking questions and knowing that there are other options and doing that research. I think that's really, you know, being an informed consumer, regardless of what you're working with, and taking and empowering yourself on your mental health journey and your spiritual journey. I just want to thank you again for taking this time. Is there anything else you want to leave people with? Like, what resources or things have helped you in your journey?
Oh gosh.
Oh,
Well,
top two.
different experiences I've had, but like a lot of it is like, I just spent a lot of years doing literature synthesis types of projects and things like that. But if I had to leave the audience with anything, I would say that, yeah, my website is spiritpharmacist.com.
Yes,
I'm an
please check
internet
out his site.
information dealer. I try to bridge the gap between like a psychiatrist or mental health professional and kind of like a shaman or alternative health practitioner. And I essentially have a few different things. So I have courses in psychedelic pharmacology. I do psychopharmacology consulting, so tailor things to individualized situations and whatnot. I have a member program, so persons want to work longitudinally to help with screening-related consulting and things like that. Also have a mastermind program that is really, I think, for professionals that even want to get into almost like a screening role or a screening position around this. So if you haven't checked it out, I would just recommend going to spiritpharmacist.com. I've got some free resources and blogs there if
Yeah,
you want to
please,
start with
definitely. I
those types
definitely
of
would
things.
recommend
Yeah.
looking at your site for as a source, as a resource and as a community resource. So thank you again so much, Ben. You've been generous with your time and your information. And I'm just deeply grateful for all the work that you do. And I know you've made a difference in this space because of your work.
Thank you so much, Sandra. It's been a pleasure being with Psychedelic Source today.
Thank you for joining me on Psychedelic Source. If you found value in today's episode, please subscribe wherever you get your podcast and share with others in our community. And if you're a psychedelic practitioner, therapist, or coach looking to identify blind spots in your practice or determine next steps for moving it forward, take the first step by visiting psychedelicsourcepodcast.com. Until next time, remember, start low, go slow, and stay connected to your source.